Support for this podcast comes from Bryn Mawr Communications. BMC produces a number of informative podcast series spanning a variety of topics in ophthalmology. Discover a new show at itube.net/podcasts. Welcome to the second season of Case Studies in Treating Ocular Surface Disease. Today, Dr. Chris Starr leads a new expert panel of Drs. Preeya Gupta, Douglas DeVries, and Leslie Odell as they deliberate on a myriad of interesting cases across the ocular surface spectrum. In our first case, Dr. Preeya Gupta discusses a patient with foreign body sensation who remains symptomatic after a combination of antibiotics and artificial tears.
Excellent. Well, welcome everybody. Thank you so much for participating and being here for this case series entitled The Treatment of OSD or Ocular Surface Disease. We've got an esteemed panel as always, Preeya Gupta, Leslie Odell, and Doug DeVries to discuss some very fascinating cases from each of their personal practices. And I'm just simply here to kind of wrangle everybody in and manage this to some degree and moderate and hopefully add something of value to the proceedings. But to get things started, let's introduce Preeya Gupta. And Preeya is going to talk about a case of MGD from her practice. Preeya, take it away.
Thank you so much, Chris. So we're going to start by going over a case, and then hopefully all of you will add your insights. So this is a 45-year-old woman, and she complains of, typical symptoms: chronic foreign body sensation, fluctuating vision when she reads. She's been treated with cyclosporin for about 9 months, and she's had some mild relief, but she still remains symptomatic. She also uses artificial tears, lid scrubs, and compresses, and she does have a history of rosacea. Her clinical exam, there's an altered tear film with a reduced tear breakup time is 4 seconds. On her lid margin, there's fine telangiectasias, even some early, maybe not ulceration, but breakdown of that lid margin, a number of capped glands, and certainly some atrophy on meibography. She also has an abnormal osmolarity and a weekly positive MMP9 test. So what are the treatment options? I'm going to, toss it out to this esteemed panel. When you look at this patient, what do you typically think are your first go-to in somebody that has been on cyclosporin, still symptomatic, and has a significant MGD?
I think at this point, we really need to look at a lid procedure and trying to clear up the lids and take a look at that meibum and see what that's looking and whether it's actually functional or not, because we're looking at the meibography and we know the structure is bad, but what does the function of it look when we express it?
In these cases, they're always multifactorial, and there are always so many things to do, often simultaneously. And so I agree with Doug, a lid procedure makes a lot of sense to get the glands working a little bit better. I love objective data, as I think we all do, and MMP9 is a fundamental test that I often do in all these ocular surface patients. And when I see a positive, whether it's weakly positive or strongly positive, if I see a red band, I know that these eyes are inflamed, and I'm going to do whatever I can to get that inflammation decreased. And so this patient is already on a topical immunomodulator, but still MMP9 positive, which is often the case in these more advanced cases. So of course, in this case, I would also add a topical steroid in my practice, a moderate potency topical steroid for a week to 2 weeks to get that MMP9 hopefully turned negative.
I think in this case, I would be thinking topical steroids combined with some kind of meibomian gland clearing treatment, whatever that might look like.
I love it. We all think alike. So I also, if I see the MMP9 being elevated, feel compelled to add a topical steroid. And then for her gland clearance procedure, I actually chose combining Ilux and Blefex. And we can go over these procedures, in greater detail. I've got a few slides here, but I chose the Ilux in particular because I like that with that treatment, you can actually titrate the pressure and actually see what's coming out. And in patients that have more moderate atrophy, it can be a little more challenging to actually express that meibum out. But I also chose to pair it with BluffX because of how her lid margin actually looked. If you remember, she had kind of that, just that red layer, that kind of peeling, yucky. I know it's a very scientific term. Just that, somewhat, it just looks like it needs to be cleaned properly is sometimes how I describe it to patients. But I like the combination of those two therapies because that combination of therapy really allows not only for removal of that debris and keratinized tissue. That's really, what that film is. That's also leading to further inflammation. But combining that with, a device that has excellent safety and efficacy for applying heat as well as unblocking the glands. There is direct visualization and control of the actual pressure that is placed. I want to say 3 or 4 weeks after, I usually check them back. And so, there's much less of that angry, inflamed lid margin. It's amazing how many patients actually have microscopic debris on their lid margin and on their lashes. And that really is not very friendly to the surface. And it causes, and it can trigger a lot of that vascularity that we see. There's just a much better profile to the lashes, and then of course to the lid margin. She did have an increased tear breakup time, almost doubled from 4 to 8. She was less symptomatic. And so, I think sometimes there's a synergistic effect with these procedures. And I think that, we shouldn't be shy to combine lid margin debridement with the heating and obstruction relieving procedures. What's for you guys? What are your experiences with combining these technologies or others?
Yeah, I don't think I've ever done a LipiFlow or iLux more recently without doing some sort of debridement first. And I have been using the BlephX for a while now, and that is my go-to micro blepharoexfoliation device. But I will, and I love doing these webinars and educational events with optometrists and MDs and ODs because I find I learn a lot of things and hear certain things that I never have heard before and sort of alter my practice. So the other day I was doing one of these with Scott Schachter and Maria Markulis, and we were talking about blepharoexfoliation, and they were saying how they sort of take a toque blade or a golf stick and only debride right over the meibomian glands and never go past the line of marks. And of course, I'm sitting there thinking like, well, I'm not sure what the line of marks is. And I take this BlephX device every time I do this and just, debride the hell out of the entire, the lashes, the lids, the lid margin, and just wipe out everything I can see. And then I'm thinking, have I been doing this wrong? Should I be more careful with the BlephX device and sticking to just anteriorly or what? So I don't know. Now that we have optometrists on here, what do you guys do? Are we making mistakes by using BlephX and wiping out the entire lid margin?
Yeah, well, I don't think so at all, Chris. I think that going forward with that and getting up and over the line of marks is fine because we sometimes see such scalloping on that, and that's going to affect the tear foam. So yeah, I don't stop shy of that either.
Good.
I think that maybe the thought there was the golf clubs, the golf spud is a little bit, has a sharper blade. Maybe they just don't want to cross that line of keratinization, but BlephX with, the way that BlephX works and the foam and the solution that we're soaking it in is pretty mild. I actually like to go just like you're doing through all the lashes, but then onto the meibomian gland orifice to really help break through that biofilm.
Yeah, I think it's really important. I mean, I think the BlephX is great for getting all that buildup on the lashes and the base of the lashes, the anterior lid margin. Sometimes there's Demodex there, sometimes it's just scurf. But I agree that before doing any of these thermal pulsation procedures, it is important to get the keratin and the uncap the meibomian glands so you can get that flow out. And I think the BlephX works pretty nicely, the golf spud, and whatever your debridement tool of choice is. But it does make a lot of sense to sort of scrape that the MG orifices.
Not to mention just how you can get the patients feeling better quickly. The nice thing about iLux is you do get an almost immediate response from patient symptoms, right? Right after you do that procedure. But if you're using something like LipiFlow in a case like this, that symptom relief comes a little bit later down the line after the treatment. But when you pair it with something like micro exfoliation, they see it's like leaving the dentist after not having been there for 7 years, and your mouth feels so much cleaner. So they like immediately feel just good. So, I think if anything, when I'm in talks like these, I think to myself, who should I not be doing that treatment on, right?
Yeah, I couldn't agree more. Well, I'm glad that you guys all are on the same page. And with that, we'll wrap up this case and go on to the next one.
In this next case, Dr. Douglas DeVries shares a case where thorough treatment made all the difference for the patient's ocular surface prior to surgery.
What I'm going to talk about today is really surface optimization and using thermal pulsation prior to cataract surgery. So, I've been in a referral center for the past 29 years that I helped co-found. And with thermal pulsation, this is something that, when you have patients that want to get to surgery as soon as possible, you can go through some of the other treatments that are going to take a little bit longer. We found this is the fastest way to really get that surface optimized, to get the kind of readings that we want to get the patient to surgery as soon as possible. So this was a 67-year-old white female, bilateral cataracts, speed score of 14. So that was up there pretty good. Osmolarity increase as well, and a mild positive. So, and the mild on the inflammatory, that means it's not just faint, but there's a definite color on there that you can look at pretty easily. And then we, of course, saw some staining, 1+ central corneal staining, looked at the diagnostic expression on this patient. So we were looking at both form and, structure and function, and seeing that this patient had some really discolored meibum, and decided that, as we looked at meibography and we see some twisting, we see that. And I think it's really important that when you look at meibography, you also are still going to press on those meibomian glands to see the quality of the meibum, because sometimes somebody can have good structure and they're inspensated and they just haven't converted yet at this point to really dropping out at that point. So the meibography didn't look good. So what we decided to do was use the sustained iLux thermal pulsation. It's so interesting because when we talked about the microblepharal exfoliation prior to me, on any thermal pulsation, that's synonymous with we're going to do that first. And gone from the point of using a debrider to actually going on and using the BlephX on that, just because it does such a good job of opening those orifices and get the best possible. So what we did is, after 2 weeks of treatment, we repeated the OCB. And what I want to show is what the meibum looked like. And what happened is we were expressing, and you can just see this meibum wouldn't do any good at really holding that tear together and preventing evaporation. You can just see how thickened it is and the discoloration that we were getting. And it matches up. And I like the idea that we can customize and really hit the meibomian glands that in meibography we feel are going to be the most productive, and then concentrate and stay on those until we get a good expression. So I think through the thermal expression, we're very confident on that. And then what we did is, when we took and we repeated the OCBs, and I'd just like to kind of go out instead of trying to find all the numbers in there. And basically the right eye changed from an IOL power of 15.5 to 14.5. So we had a diopter change as a result of optimizing the surface. And the left eye, we had a half a diopter change. And to me, that is just such real changes to the patient if you can do that simple procedure. Now, of course, we were going to follow on, and we were going to use immunomodulatory therapy on this patient and have them continue and put on a supplement. But my feeling was to get them to surgery as soon as possible, because that's what the patient was wanting, is let's try to optimize it and do that. And we certainly had a difference. Any thoughts on the surgical optimization?
Well, this is a topic that is certainly near and dear to Preeya and our hearts, because we spent many years working on, with the Ascaris Cornea Clinical Committee, working on this sort of area of ocular surface disease and cataract and refractive surgery, and how to identify it, how to manage it preoperatively, how to the visual impact. This is what we would call visually significant ocular surface disease, because it certainly has an impact on vision, visual quality, visual performance, and IOL planning, which is critical and tantamount to the definition of visually significant. So I think this is a very important case. This is a case that we see that all surgeons and optometrists and people who co-manage see this every single day. And it's great that you identified this prior to surgery, identified it as visually significant, and treated it, because as you saw, that it dramatically changed the IOL calculation and the toric axis, and and all of that translates to improved surgical outcomes and patient satisfaction post-operatively. So it's a win-win.
Yeah, I'd agree completely, Chris. I think that, the one thing that still always stands out to me is that we spend a lot of time making sure we have good biometry, that, we're using femtosecond laser, Aura, like all this advanced technology, but sometimes it's the simplest things like treating pre-existing ocular surface disease that really will actually, make a meaningful difference. And, a diopter is certainly meaningful, but even a half diopter, especially in our premium technology patients where residual refractive error of even a half diopter is a problem. So I think that, whatever practices can do to start screening patients, even using a questionnaire while patients are waiting to be dilated, I think is a great start. It doesn't have to be complicated. And certainly there are, algorithms to help guide you. And I encourage everybody to look at them and see how you can incorporate it.
Support for this podcast comes from Bryn Mawr Communications. BMC produces a number of informative podcast series spanning a variety of topics in ophthalmology. Discover a new show at itube.net/podcasts.
It's just such actually, an honor to be doing this case actually with you, Dr. Gupta and Starr, because I use the ASCRS guidelines now as my pre-surgical dry eye evaluation, and have long since wanted something like that, having had worked for a refractive surgeon many years ago and dealing with all of that post surgical dry eye. So that resource is definitely very widely used, I think.
Thank you.
Thank you.
And wouldn't you agree, Leslie, that especially even after refractive surgery, if somebody's going to be unhappy about something, I feel like the unhappy people are mostly dry eye patients. And, it seems like such a simple thing. It's not, oh, they can't see through this technology, or, oh, the laser didn't do what it was supposed to do. It's their surface. And sometimes the simplest things are really worth spending time on.
Absolutely. I actually just had a patient today that was a monovision cataract patient that has been unhappy this past year because of the monovision, although she showed up without glasses in the office. Okay. And that's what I said to her. Well, first of all, when do you wear your glasses? Never. But on her, intake, she was high on her symptoms. She's saying, I feel my eyes all the time. I'm uncomfortable. And her surface was just filled with keratitis that was not being treated. So I'm actually hoping by rehabbing her surface, she'll actually appreciate the vision she was given with monovision.
Yeah.
That's great.
All right.
And this is also the ocular surface and that central staining that Doug showed. I mean, it's so critical, not only to IOL power calcs, but also, with a lot of these patients, whether they're getting a multifocal or just a monofocal toric, the axis of the astigmatism is so important to get right too, and that staining will throw that off so dramatically, like your data showed, and before and after. And this has been published too in the peer-reviewed literature, how high hyperosmolarity and other ocular surface abnormalities can lead to very wide-ranging metrics when it comes to axis and IOL power. Great. Well, shall we move on? Leslie Odell, the next case is yours.
In the final case, Dr. Leslie Odell discusses a case involving a symptomatic elderly woman with newfound light sensitivity and a prominent history.
Okay. So this was a patient that I had a few months ago now that came in with this complaint that she was unable to keep her eyes open. And we'll just walk through her history. So she was a 69-year-old Caucasian female, and just had noticed that over the past several weeks, she's been having all this light sensitivity, hard to keep her eyes open. So she's actually been limiting even how she's driving, because she just doesn't feel, safe, because she cannot keep the eyes open. She had a longstanding history of dry eye disease. And actually, I had seen her in another practice years prior. So she was diagnosed already with meibomian gland dysfunction and history of lipoflow, a long time ago, 2013. She was using Restasis in both eyes twice a day. She was on oral nutraceuticals with an omega-3 supplement, and she still was using a lot of lipid-based tears throughout the day. She had a lot of things that kind of were fueling her fire when it came to inflammatory reasons for dry eye. She was an RA patient, hypothyroid, medications also contributing to some of her symptoms. But really, I always like to kind of dig into the daily activities with patients, because this is where our treatments can really improve quality of life. So for her, she was no longer doing things she liked. She wasn't reading in the evening. She wasn't watching television. And then more concerning, like I said, of late, was just her unwillingness to drive because of just this inability to keep the eye open and the light sensitivity she had been dealing with. So this was her exams. She also had a very high speed survey, and just like Preeya was saying, and Doug's case as well, symptom surveys are so powerful. So speed 20 out of 28. Obviously we need to do something to help this patient feel better in her eyes. Hyperosmolarity with some asymmetry between her eyes, positive inflammatory dry. I like to grade the glands, counting the number of secreting glands. So if I'm counting 15 using that meibomian gland expressor, she was at 0 for both eyes, even though she had a thermal pulsation treatment in her past. And then she actually presented with filaments on her cornea. So she was not an early entry into dry eye disease. Her one eye had severe keratitis, the other eye had filaments. So my first course of action was to actually compound the mucomist and get her started on that, to try to quiet down the filaments and improve the quality of her surface before really targeting her glands. But obviously that's something that needs to be done. When she came back, she said that compound did the trick, which is just funny to hear her say that, but we had to send her out for that medication. She could go outside. She actually drove herself to this appointment. We cut her speed survey in half just from that, but her inflammatory remained positive, still hyperosmolarity. And then, where do you kind of go from here? And that's where I'd sort of say to you, for me, I was thinking about, introducing my MG clearing treatments at this point. But what even would you be thinking about her, with the Restasis history, with that inflammatory positive still?
And Leslie, did you say that you did put an amniotic membrane on the eye?
No, I started with mucomist, but on my list, was if I wasn't going to get anywhere with the resolution, that definitely was on my list. Was amniotic and even Regenerize. Yeah, she is not an ideal patient. I'm actually was more impressed with myself that I was able to do LipiFlow in 2013 because has very tiny eyes too. So, I think I could do Procara or something, but I was maybe sometimes I say I get in my own way with managing the patient.
Well, I think that's why I think it's great to have an option like iLux now in those patients in whom you might not be able to get that activator into a tight lid. I've had to cancel several LipiFlows over the years because I'm pulling the eyelids and I just cannot get the damn thing in. But this is a patient. Obviously, there are a zillion things that you could do to help this patient, and usually it's going to take a zillion things to get a patient like this feeling better. It sounds like you're off to a great start. She's feeling better. She's more functional, but there's still a lot of work to do. I think, anytime I see a filament in my practice, I will take a Wexel, a dry spear, surgical spear, Wexel, whatever it is, and just touch the base of those filaments, and they'll come right off, and you don't have to take the risk of a sharp object like a forceps or something that might, if the patient moves, you might ding the cornea, create an epithelial defect. So the dry Wexels are great for these. I always remove them. They often do come back if it's not adequately treated, and it is hard to adequately treat these. And you're doing mucomist is something I do use often. There is some evidence that can work. Muro ointment at night, Muro drops during the day for decreasing the mucus, and of course treating the dry eyes, increasing aqueous production. Usually with the filaments, there's a mismatch between mucin and over mucin production, less aqueous. And your patient has, I think, 2 autoimmune conditions. So right there, she's a setup for aqueous deficient dryness, as well as evaporative dryness, hybrid dryness. So plugs, I think, would be a reasonable thing to do. You probably did that. And a lid procedure. And Regenerize and serum tears and amniotic membrane
Just
and
about everything.
PCLs. Yeah, I mean, I think
the best case because everything fits here.
Yeah, but these patients need that aggressive, that aggressive multifaceted treatment. I mean, they need it.
And I think also, what's nice about, iLux and, all of our treatments is you compare them together to get ultimate success. So I think ultimately for her, after we cycle through some IPL treatments to just help control some of that lid inflammation and then pair that with IPL, she should be continuing to feel a whole lot better as well. But what's interesting is a lot of times I feel, and why I wanted to kind of go the route of a complicated case like this is a lot of times you might just stall on the cornea, I feel like, and just keep trying to target the inflammation there without realizing this woman, has no functional glands. If you don't try to open the meibomian glands, the keratitis will continue to persist and cause problems for you.
Something I do a little differently now, really within the last year than before, is also with this severity looking for and do corneal sensitivity testing to find out how much neurodown regulation that's really had. And is this like a stage 1, a Mackie stage 1 neurotrophic keratitis that we have going there? And I think the only way to really do that is, look at a lot of and test sensitivity on a lot of corneas to tell, especially in something like this, it might be bilateral, is when you actually have that down regulation.
Yeah, and on the flip side of that, I was in this case, when I have patients who have that extreme photophobia, which certainly can be explained by the filaments and the PEE and the severe dry eyes and filamentary keratitis, but I also start thinking a neuropathic pathway as well. And this would be a great patient to not only check corneal sensation to see if it's reduced, and I did just learn recently that people can have neuropathic and neurotrophic keratitis at the same time, which is a mind blower from a diagnostic perspective, but it can happen. But this is another patient where I would do the proparacaine test, put in a drop of proparacaine and see if she still has symptoms of sensitivity or discomfort or pain. And I would almost bet that this patient would probably have a component of a neuropathic pain, which is why she's so intensely photophobic and in such pain. And then of course you get into things like gabapentin and naltrexone and those types of CNS pain treatments.
I love hearing all the comments. I was just gonna say that, sometimes our autoimmune patients, we automatically assume that they just have aqueous deficiency, and you can put Sjogren's in this bucket, RA, the whole gamut, mixed connective tissue, but often it's just that chronic inflammation is causing widespread, destruction. And that's why, this, unfortunately for this patient, everything's impacted, and why you have put everything on the differential of things that we can use to treat this patient. And I agree with all of the treatments you've listed. And I kind of take the same approach, Leslie, where I go bit by bit. I start with what's going to work fastest to, okay, what's urgent, emergent, and then, kind of piece our way through it. But you setting her expectations for that and telling her, hey, you've got a lot of things going on. And I find explaining to the patient how their autoimmune disease is impacting their eye is really important, because they don't always think of their eyes as, a source of issues related to autoimmune disease. So kudos to you for all those treatments, and hopefully she actually turns the corner and continues to stay well controlled.
Yeah, I love these complicated cases, and it's an example of why a lot of doctors sort of shy away from dealing with these patients, because it is complicated. It's very complicated from a diagnostic perspective because it's multifactorial and there are lots of different diagnoses that you have to make, and then treat each one specifically. And that's complicated, and it takes a lot of time in the office to explain it all and to set expectations appropriately and go through the risks and benefits of all the various things. So these things take a while, but the reward is that you can really, truly, really help these people. And these people are often the ones who have seen a zillion doctors before they've seen you. They're desperate. Their quality of life is just severely decreased. They're depressed, some have suicidal thoughts and things like that. And, you take the time like you did and do all the right things and, show empathy and really, and, it's life-changing for these people. So these are great cases. I want to thank everybody for presenting and having a vibrant discussion.
Thank you to our panel for an engaging and informative discussion. And thank you for listening.